Good morning, everyone. We are going to get started now. I think people are still joining, but we are going to go ahead and get started on time. Welcome to the informational webinar for the Illinois Medical Respite Capacity Building Initiative Request for Applications. This webinar is set to last until 9:45 a.m. We may have a few extra moments at the end for questions. My name is Rachel Thomas. I am a program manager here at the Illinois Public Health Institute. Julia, would you like to introduce yourself?
Sure. Good morning, everybody. My name is Julia Dobbins. I'm the Director of Medical Respite at the National Healthcare for the Homeless Council, and we're really excited to be partnering on this project.
Great. Alyssa, would you like to introduce yourself as well?
Sure. My name's Alyssa Bassler. I'm the CEO at IPHI, and I'm really excited about this webinar and this initiative, and thank everybody for joining us today. Thanks.
And Jess, would you also like to introduce yourself?
Good morning, everyone. Thank you so much for joining us. Happy to be here with all of you. Jess Lynch, she, her pronouns. I'm a program director at IPHI and happy to see some familiar faces and new folks. So we appreciate y'all being here with us today.
Absolutely. Okay, so just to get us started, this is the agenda for today. We'll introduce you to some of the key players in this initiative and then go into depth on the program background and purpose. We'll talk about the RFA, specifically each portion, as well as how to submit the application. There will be a Q&A at the end, which we'll go over in the next slide, how to submit questions to. And then following that, we'll have additional information on how you can submit any questions that weren't answered during the Q&A to our FAQ. So just some guidelines on how we'll manage questions throughout the informational webinar. Please enter any questions or comments you may have into the chat, and remember to keep yourself muted throughout the presentation. We'll answer questions at the end of the webinar during the Q&A session, and any questions that we don't get to, we will post in the FAQ. Also, feel free to introduce yourself in the chat. You can use your name and pronouns, as well as what organization you're from and why this topic is important to you. Okay, Alyssa, would you like to talk a little bit about IPHI?
Yeah, thank you very much. On the slide, you can see our mission. We really work with stakeholders and partnerships across multiple different sectors to advance the health of communities and to advance health equity. So housing is one of those sectors where we know there's a real deep impact on health. And so we work in the housing space as well as the health space and try to make connections between housing and health. Since 2017, we've been working at that intersection and facilitating various kinds of systems collaborations between hospitals and housing organizations and other providers serving people who are experiencing homelessness. And in particular, we worked on medical respite some of that time before that, and then in particular, the work around medical respite really increased during the early days of the pandemic when we were working to support people experiencing homelessness and people serving people experiencing homelessness around the congregate living situation and people who were coming out of the hospital who had experienced COVID and so on, and needed someplace to stay in between going back to whatever their the shelter system and that sort of stuff. So that's when we really started to ramp up our work on medical respite. But we have been working on this for a while and are excited to be able to launch this initiative in partnership with DHS and NIMARC. Thank you.
Great, thank you for that, Alyssa. Julia, would you like to introduce us to NIMARC?
Sure. So like I said, my name is Julia Dobbins and I work for the National Healthcare for the Homeless Council. And the council has been working in medical respite for over 30 years. And in 2020, we launched the National Institute for Medical Respite Care, really to expand the breadth and depth of our medical respite services. The first convening of medical respite providers happened in the year 2000 in Chicago, actually, and were brought together by the National Healthcare for the Homeless Council. And from that convening, we launched the Respite Care Providers Network. And really years and years of on-the-ground learning, development of best practices is what made us decide to launch the Institute. So NIMARC launched in 2020 and has really created a lot of opportunities for us to help communities expand their respite services and to help systems integrate medical respite care. So NIMARC is the first national institute to advance best practices, expert services, and state-of-the-field knowledge in medical respite, also sometimes known as recuperative care.
Great. Thank you so much, Julia. Jess, would you like to talk about Home Illinois and IDHS's role in this initiative?
Absolutely. Thanks so much, Rachel. Good morning, everyone. Given that the Department of Human Services was not able to join this call, I am going to just briefly share how this fits in with the Illinois' plan to prevent and end homelessness. I think most folks on this call are quite familiar with that plan that was developed over the course of last year under the leadership of Christine Haley and others at the state. I put the link in the chat to that plan, and as most of you all are very familiar, medical respite is one of the key strategies that is listed for the first couple years of implementation of that plan. So if you look at page 9 of the plan, you'll see that there are 4 or 5 key strategies outlined for really laying the foundation to prevent and end homelessness in Illinois, and one of those is medical respite. One of the other hallmarks of the plan is that IDHS really worked with other state agencies to secure commitments to how those agencies and departments are planning to act to support the plan over the course of this year and the coming years. And the first commitments on the part of HFS, Healthcare and Family Services, was to start to explore how to create 2 types of benefits within Medicaid. So one being medical respite and one having to do with housing tenancy services. And so this funding opportunity this year is the rollout of some of the work that IDHS and HFS are doing to begin to hopefully implement those commitments within that plan to create opportunities for greater capacity for medical respite across the state of Illinois. So this is really a key initiative for DHS and HFS as they work to implement this plan.
Absolutely. Thank you so much, Jess. Okay, so just a bit of background on this project. Jess already covered a bit of this, but IDHS has funded the Illinois Public Health Institute to develop an Illinois medical respite capacity building initiative, including this initial funding for medical respite capacity building and technical assistance. This request for applications will support up to 10 Illinois communities to plan for or expand medical respite with funding to build capacity for medical respite services in their community. So this project really is going to support 2 tracks of applicants. Track 1 is medical respite development. So that is for communities hoping to develop new medical respite services. And then track 2 is for medical respite expansion. So that is specifically for existing medical respite providers hoping to expand their services. For this award will fund up to $25,000 to each awarded lead partner. The award period is from March 6th until June 30th. In terms of the payment schedule, awardees will receive 50% of the budgeted amount upon execution of an agreement, and then the remaining 50% will be paid on a monthly cost reimbursement invoice after that initial 50% is depleted. And all invoices must be received by July 15th, 2023. In terms of reporting, we will need to collect a final summary report on activities, and we will be submitting a format to you all for that summary report. We'll also need a final financial report on any expenditures via your final invoice. In terms of what we expect from each awardee, each awarded lead partner is expected to convene partners to A, assess the state of medical respite capacity in the communities that they serve, also to develop a plan to increase local capacity for medical respite, including the identification of successes, opportunities, and barriers to implementation, and the stakeholders and partners involved. They'll be expected to engage in at least 2 technical assistance meetings with NIMARC and attend 3 learning collaborative meetings hosted by NIMARC. The dates for those are March 13th, April 10th, and May 8th. And as Jess kind of spoke about a little bit, you'll also be expected to contribute to policy discussions related to opportunities for Medicaid coverage of respite care. Julia, would you like to talk a bit more in depth on the technical assistance and the learning collaborative element?
Sure. So as Rachel said, part of the expectation of participants is to participate in 2 TA sessions with NIMARC and then also the full learning collaborative. The purpose really of the TA sessions is it's an opportunity for the NIMARC team to meet with you and your team individually to really discuss what's happening locally for your community as it relates to respite, what we need to take into consideration because every community is different. Every respite program really should reflect the unique needs of the community with which they are based. And so part of our goal here is to provide really community-specific tailored technical assistance. So we'll be working with you to get a sense of what's the lay of the land, how do we determine what the needs are, and how can we help you achieve the goal of planning for expansion or development of medical respite services. Another goal of the TA sessions is there's a lot of resources out there. There's a lot of tools that have been created, a lot of lessons learned around the implementation of medical respite services. And we don't want you out on an island on your own feeling like you have to recreate the wheel here. So this is an opportunity for us to make sure that you have the resources that you need to achieve your goals for this project. So we're really excited about having an opportunity to meet with you guys one-on-one to get to know your communities and really what your needs are around respite. And then the Learning Collaborative is more broad. So all 10 communities that are participating in this project will be attending the Learning Collaborative. And in these Learning Collaborative meetings, we'll be touching on things that are through lines across all respite programs. Yes, all respite programs are unique, but there are things that every respite program has to manage. So we'll be talking about eligibility requirements, discharge planning, partnerships, funding, evaluation, all of those pieces. Really talking about best practices and standards for respite. I think this is also going to be a good opportunity for providers across the state to talk to each other and learn from each other. And we're going to bring in other providers from other states to share their experience and best practices and lessons learned.
Great. Thank you so much, Julia. Okay. In terms of the eligibility criteria for this initiative, organizations must have the capacity to execute the requirements of this project, including direct experience working with homelessness populations or a partner that has experience working with homeless populations, the ability to convene relevant stakeholders and partners, capacity to dedicate staff time to manage this project, capacity to manage the funds and produce financial program reports. And specifically for track 2, they must be either an established medical respite program or partnering with an established medical respite program. And please note, only one project will be funded in a single community or service area. In cases where we receive more than one application from a community, we may request that you partner with another applicant. Applicants will be selected based on the quality of their proposal, available funding, and ensuring other goals of the program like diversity in geography and organizational types. We want to just make clear that we want to have a good mix of selected awardees. We want to make sure the awardees serve the entire, that the awardees are spread geographically and are diverse as well. So we want to honor that in the selection process. Awardees are expected to engage people with lived expertise as well to inform their planning, and their application and budget should reflect that, and provide compensation for the contributions of people with lived experience. So the priority areas that we are focused on, again, organizations that serve people experiencing homelessness, also organizations that have geographic reach in and or prioritize serving vulnerable communities, organizations that provide behavioral health or substance use services, and organizations that have a commitment to housing first or low barrier services.
We are going to get this. I'm loving it.
I just want to review the timeline as well. So we released the application on January 31st. We're hosting the webinar today. The deadline to submit any questions you may have on the RFA or this webinar is February 10th. And then on February 21st, our applications will close at noon. So you need to submit all of your application materials, and we'll review what materials you need to submit and how to submit them a little later on in the presentation. But all of those are due at noon on February 21st. By March 6th, we will have selected the awardees and notify them, and we'll also start the award period. March 13th is the first convening of the Learning Collaborative, and by March 17th, we expect to have signed statements of work and your subcontracts due. The second convening is on April 10th, the third is on May 8th, and on June 15th, we expect your summary reports due, and then June 30th is the end of the award. So in terms of submission, what materials should you submit for your applications? So your complete applications will include the RFA document that was sent, I believe, to most of you by email, but it's also accessible on the IPHI website. We'll be posting that on the following slide, I think, or one of the following slides. So it will include that completed document, including the project budget form, which is found on the very last page of the document. You don't have to create your own budget form, just use the one that we provide. You'll also need a letter of support from a member of senior leadership at your organization. Track 1 applicants, which are applicants that are applying in partnership with another organization. They are developing medical respite providers. They'll need to provide a letter of support from one or more partner organizations that will be collaborating on the project. All of these application materials should be sent directly to me via email. My email is rachel.thomas@iphionline.org. We'll also show my email at the end of the presentation, so you all will have access to that. Jess, perhaps you can put that in the chat box as well. The subject line for your application should be Medical Respite RFA. And again, those applications should be submitted no later than noon on February 21st. All right, Julia, would you like to talk about the different tracks of the application?
Yes. So Rachel went over this a little bit, but to dive a bit deeper, for the tracks, the first track is really focused around communities that don't have medical respite services yet, but are wanting to develop medical respite care. And I saw the question in the chat around how are we defining community? I think part of it is we didn't want to say program because programs don't necessarily exist yet. So what we mean by community is a partnership. So for the first track, whether you are very new to respite and are just considering it and maybe have had a conversation with another organization about it, or if you've started having conversations or started doing some planning, this is really an opportunity to provide some funding and have some technical assistance around bringing all of the stakeholders to the table to start planning what a respite program would look like, what you would need to have in place, and getting a really clear sense of what need you're trying to meet with the medical respite program. So again, track 1 is really for communities that are in this developmental phase, that are in thinking about what respite could look like and needing some support around how do we develop this, what partners do we need to have at the table? How can we get this up and going? So that's track one. Moving to track two. So there are a handful of medical respite programs already up and running across the state, not a ton. Certainly there needs to be more services, but there are some really strong programs that already exist across the state. And so there's an opportunity here for track two for already established medical respite programs to start thinking about how to expand services, expand beds, and or do some innovation potentially with this project. So if you are already established medical respite program and you are wanting to potentially add more behavioral health services, bring on a new partner, maybe expand your beds, maybe you have a really innovative idea for a new data collection system or EHR system, something to really advance your practice of medical respite care. That is what track two is for. One of the primary differences between track one and track two is first the development piece, but for those in development, we are asking that you apply in partnership with another organization. It's a core component of all medical respite programs that they operate in partnership, whether it's your partnership for a referring agency or how you discharge or who your clinical provider is or behavioral health provider is. Respite programs operate in partnership with other service providers. So for track one, we want you to apply with another organization or a partner. Track two, you don't have to apply with a partner because your services are already established, but we do want to hear about what partnerships you have in place, and we will be thinking about where's there possibility to expand some of your partners. And we are really interested to hear from established programs, where do you feel like there are barriers and what is the highest priority for expansion or innovation with your program?
Great. Thank you, Julia. Okay. So the maximum budget for this project is $25,000. Allowable costs will include salaries, fringe consultants or contractors. Specifically, when we do say consultants and contractors, that is where you would invoice for people with for engaging people with lived experience on your project. You can also invoice for supplies, travel, occupancy, printing, communications, training, meeting costs, other and indirect costs. Budget should include compensation for people with lived expertise, just like I mentioned, but equipment purchases over $5,000 may require additional approval, and capital expenditures are not allowed. Okay, I think we are going to get started with our Q&A. Just a reminder, please put any questions that you have in the chat, and we will answer them in the order that they're asked. So I just want to skip to the beginning. Eugenia Olison asked, can you define community? I think Julia kind of touched on that a bit. But yeah, so I think it also relates to partnerships as well. So for example, we want definitely like anyone who applies should be applying in partnership. Just like Julia mentioned, medical respite is something that requires partners and those referral relationships. So community definitely refers to those relationships. I think, Jess, were you going to hop in with a response as well?
Yeah, thank you so much, Rachel. And for folks who, I know that those who are sharing their screens can't see all in the chat. So I'll just also reiterate what we have in the chat for anyone who's watching this recording. So we will plan to respond directly to the question about how community is defined in the written FAQs, which will be posted on the webpage. We really appreciate both folks who asked this question. We have been purposefully broad in using the term community, since we know that different organizations and different parts of the state will define community differently in the project you propose. But we will provide a more direct answer to the question of defining community when we post the FAQs. So thanks everybody for those questions.
Absolutely. Thank you so much, Jess. Okay, I think the next question is from Eric Johnson. Jess, please let me know if I'm missing a question as well. It says, with track 2, what are you anticipating the outcomes of the project to be for the grant recipients? Julia, did you want to address that a bit?
Sure. So this is a short time frame in this project. So we're not expecting you to achieve expansion or achieve innovation. This is really an opportunity to reflect on what's happening currently, where your program needs or would like to grow, and then really having a clear plan that addresses what are the opportunities here, what are the barriers here, what needs are we not able to meet currently given our restrictions, whether they're staffing, partners, funding, whatever it is. So I think the development of a plan for either expansion of your services or a new innovation for your services, I think that the purpose of this project is really plan development, creating some time and funding for communities to come together and be really mindful in their planning process. So I think that, I know that still sounds a little bit vague, but part of that is it's going to be different depending on the program. So whatever that means for your specific program, where you're seeing a barrier and how you can address it, really thinking through what that project would look like if you had funding moving forward to implement that project. Does that help, Eric?
I thought it was a great answer.
Yes, that does help. Thank you.
Okay.
Great. The next question is, can you explain capital expenditures? Alyssa, do you want to talk a bit about that?
Sure, thank you. So this is a restriction on the funding from the Department of Human Services. So in general, it would mean you can't spend the money on buildings, building repairs, other kinds of resources like that folks would, buildings and things like that. We can get a full, we'll also get another, we'll put a full definition of that in the FAQ as well, but generally it means we're not building any new buildings or repairing buildings with this funding. It's really focused on design and planning, as Julia described.
Absolutely. Thank you so much, Alyssa. Okay. The next question is, can you define what medical respite for homelessness looks like for the individual? Julia, you are our content expert, so please take it away.
So we feel really strongly that medical respite needs to be diverse in how it's operated. That's one of the strengths of respite, is that, again, like I said, it's really unique to the community with which it's based. But there are some primary components of medical respite that have to be in place to be considered a medical respite program. So the 4 primary components for a client is you have to have 24-hour access to a bed. It has to be a place for people to be 24 hours. There has to be some type of clinical component. It's typically a clinical issue that brings somebody into medical respite and determines their length of stay in medical respite. A lot of flexibility around that, but there is some type of clinical component that is the need for somebody to come into respite and determines when it's time for people to exit respite. Medical respite is short-term in nature. This is not long-term care. That is flexible and it's defining. The national average length of stay for a respite program is around 40-ish days, but that really depends on what type of program you have in place and what the goals of your program are. So 24-hour access to bed, some type of clinical component, whether it's clinical care on site or clinical care coordination, social services, connection to resources, case management is really important to respite, connection to primary health care home, and then really respite at its core is an opportunity for rest, recovery in a safe environment. So it's also an opportunity for education, for planning, for folks who are maybe managing a chronic illness to do some health education on how to manage that. So those are the primary pieces for respite. It's short-term, people are coming in, the goal is for them to heal or recover from an acute event, be wrapped around in services while they're there, hopefully get connected with all the resources for which they qualify, and then discharged to a more stable environment. Then that's generally the experience of what people have coming in and out of medical respite care. There's a million little pieces on the in-between there, which we'll get into as part of the Learning Collaborative.
Awesome. Thank you so much, Julia. Was that question answered? I think that question was from Lori Hartz.
One thing I will say, just sometimes it's helpful to understand what respite care is when we think about what respite care is not. So respite care is not nursing home care. It's not bedside care. It's not supportive housing. It's not assisted living. Respite is really a short-term gap for folks who, if they had a home, they would be discharged home with some instructions and maybe home health coming in to provide services. If this person is not independent in their ADLs, if they're really needing bedside care, they're needing a higher level of care than what can be offered safely in medical respite. Most medical respite programs are not licensed facilities, so that's something to keep in mind as well.
Awesome. Thank you so much, Julia. Okay, our next question is, can you talk about what happens after the planning phase? Are there opportunities for funding to support building out this plan in the community? Alyssa, can you address that question?
Sure. Consistent with the homelessness plan, the goal is to expand access to medical respite care in Illinois, in communities that don't have it, and in communities that have something but want to expand to the track 2 kind of communities, different populations or a different area or something. As most people know, the state is always dependent on an annual budget process. So this funding is coming from general revenue funds, so it needs to be appropriated again by the General Assembly for the coming fiscal year. Part of our work at IPHI is to design the next phase of this program, which we will be doing in partnership with DHS, with the hope that there'll be continued funding from the General Assembly to fund this. So I guess the answer is sort of maybe, probably, we hope so. And that would be that's definitely our hope. And I think that we said in the RFA as well, we would also be hopeful that we can do another planning phase as well as building on the first phase of this in the next phase. Again, that's to be designed and worked with on DHS. So if you don't feel you're ready, we're hopeful that we will do, in addition to anything that's sort of a follow-on funding, we would be hopeful to be able to do some additional support for planning programs in the coming year as well. So if you don't think you're ready now, there might be another opportunity like this next fiscal year.
Great. Thank you so much, Alyssa. Okay, the next question is, should outcomes therefore be presented from each of the partnering agencies or a common set of outcomes developed by both in this collaboration project? Julia, would you like to talk a bit about that?
I mean, my instinct here would be a common set of outcomes between the two. I think part of our goal here is in the development phase of a respite program, it's the community that's going to be continuing on with the program moving forward. So these relationships that you're developing and shared goals, those need to be sustainable between your two organizations with or without support from NIMARC or IPHI. So I think the development of these relationships and shared goals around creating these services is really important as part of this process. So I think working in partnership to define what your goals are and what you want the outcomes to be would be best.
And could I just jump in here and correct me if I'm wrong, Julia? It's not limited to 2 partners.
Yeah.
Like maybe there's 2 partners who are on this, but the goal is really to bring together the right set of stakeholders, because I think there's healthcare, there's housing and homeless service folks, there's people with lived experience, there's a variety of different folks. So you're not limited to 2 partners, and we do want you to bring together the stakeholders that would be part of a longer term project.
Yeah, and I think that's a really good point. And you don't have to have everybody at the table for this application. That could be part of the goal of your planning processes. We know we have these two organizations on the same page. As we're going through the next couple of months, we want to make sure we get all of the right people to the table.
Exactly. Thank you, Julia.
This is Clarice. I asked that question originally. Thank you, Julia, for responding to that question. Now it brings me to another question. In terms of managing the funds, if we are 2 or 3 in the collaboration project, how do you see us managing the funds? Will it be one that is a lead agency, or will it be upon us to just decide who will manage the funds, or where the fund should be going if it's a 3 or 4 agency partnerships? How do you see that coming in terms of the application, or presented in terms of the application?
Yeah, I'll take that one. Yes, an organization should apply for the funds, and then if you want to share the funds with other organizations that are sitting at the table, those would go in your contracts line. The amounts that they would be receiving, and then what they would be doing for those funds go in the justification. So absolutely, we don't want to be paying 3 different organizations. We want one $25,000 or up to $25,000 award being given to one organization.
And necessarily, if the cohort decides, okay, Pats Lake County will be managing it, then we'll just have to decide how the funding will be distributed, if ever, based on the contributions or probably the outcomes that need to be achieved, correct?
Absolutely, that's part of your budget and your decision making with your partners in the process of putting in the application.
Thank you.
The only place we definitely need you to spend money is from the things is to engage people with lived experience and get some feedback and input from folks with lived experience, and compensate them for that time. Doesn't have to be a lot, but if you're going to have a focus group or key informant interviews or whatever that looks like, part of our equity agenda is that people with lived experience who are involved in designing programs that are meant to support them, and that they're compensated for their time. So that would be the only thing that is required in the budget.
Do you mean the staff that is going to implement the project?
No,
I'm sorry,
that would
I
be in
got
your
lost
personnel.
there.
Sorry, that would be in your personnel if you're paying your staff.
Okay,
People who are homeless
okay,
generally are the people we're talking about, I think, or people who have been discharged from a hospital and are homeless, and something like that. Want to consult with folks that would benefit from the medical respite when the plan is executed and you've created medical respite services in your community.
Thank you. Thank you for clarifying that.
Okay, I think that there is one final question in the chat. It is, are you aware of a successful medical respite for homelessness program in existence that we could learn from? Julia, I'm going to pass that to you.
Sure, there are many actually. We're aware of about 150, although that's kind of growing all the time, medical respite programs across the country. I'm going to put in the chat just a link to our website. There are a bunch of resources on our website. One of the things on our website is a directory of medical respite programs. Also on our website, there is a toolkit that lists some resources around how to develop a respite program, standards for respite programs. What are the core components of respite care, models of respite care, so you can think about what type of model we want to create for our community. Tons of resources there for you to take a look at as you're thinking about the development of your proposal here. And please feel free to also email me if you have any additional questions. Happy to share resources.
Awesome. Thank you so much, Julia. Okay, I don't see any other questions in the chat. So we are going to move on. The
Sorry,
next, oh, sorry, go ahead, Alyssa.
there is a new question
Oh,
from
okay.
Neil just now.
Apologies.
Nope,
Let's go back here.
came while you were saying that.
Yes, okay, we got a couple of questions. Great. Okay. Do they have models for rural areas is the question to you, Julia.
Yes, so that it's a little more unique with respite programs. Not even every state has a medical respite program, and most respite programs are centralized into the most urban areas of the state. So this is a real gap in services in most states for medical respite care, and that there are not a lot of rural programs. There are programs that are suburban that cover maybe larger counties that have rural areas. So I think I'll pull up this models of care and put it in the chat so people can take a look at it. But this would be something to identify as a need in your application, and that we could really dig deep into in the TA sessions around how can we create respite beds in a rural setting that actually is affordable and has the staffing you need and makes sense, because it is a unique challenge to create medical respite in a rural community, but really, really a high need. So let me share this resource.
And Julia, we'll get several of these links from you, and we'll put those in the FAQ so people have easily have access to some of the best resources you think you have.
Absolutely. And the following question is, are you able to send us a copy of this session's discussions? Yes, just like Alyssa mentioned, we will reiterate all the questions that were asked and answered during this session in the FAQ, as well as any additional questions that we received by email, and they will be posted on the website in the FAQ.
And I think Rachel will be posting the recording of this webinar as well.
Exactly. Yes, I will be posting the recording as well. So you should be able to reference this presentation. Okay. I'll just give a few more moments in case anyone wants to put another question in the chat. Okay. All right, so for additional information, please visit our website for specifically on IPHI on online.org. We have a site directly for the Illinois Medical Respite Capacity Building Initiative. It's iphionline.org/Illinois-medical-respite-capacity-building-initiative. Any questions that you have about the RFA, the request for applications, can be sent directly to my email at rachel.thomas@iphionline.org. For those questions, please use the subject line medical respite RFA question. And for completed RFA applications, again, please include the RFA document, including the last page filled out, which is the budget form, as well as your supplementary materials, including a letter from a leader in your senior leadership team. And if you're in track 1, a letter from a partner organization. Please send those via email to rachel.thomas@iphionline.org. And then for this, use the subject line medical respite RFA. Again, the FAQ document will be posted on that specific webpage mentioned in the first section there. You can access the FAQ document by scrolling to the bottom of that webpage and selecting Go to FAQs. It should be lit up in blue. I'm going to leave this page here for a moment just so that you all can see it. Again, following this webinar, we will be sending this information to you all as well. So you should have access to it, but in case anyone wants to just take a moment to write it down. All right. And that is all. Thank you all so much for your time this morning. Very excited about this initiative and getting started. Please feel free to reach out to me anytime with any questions you may have. And yeah, just thank you everyone for joining.
Thanks, everyone.
You.
Thanks, Rachel. Bye, everyone.
Thank you.